everybody, and welcome. I'm Debbie Plotnick, and I'm Executive Vice President for State and Federal Advocacy at Mental Health America. And for those of you who are new to Mental Health America, and I suppose you all probably do know us, we are the nation's oldest national advocacy organization, and we're about to have a birthday next month, and I think it's 115 if my math is right. Right. And we're very glad that you could join us today. Today's webinar is one of a series sponsored by our Regional Policy Council. And the Regional Policy Council is a wonderful program that we're very proud of. And I have the great privilege of coordinating it along with some help from Alicia Coffey, our Vice President for States Advocacy. And today you're going to hear from some very wonderful speakers, including one of our Regional Policy Council representatives, Ben Harrington. And Ben is the CEO of the Mental Health Association of East Tennessee. He's also a board member of Mental Health America. And another hat that he wears is chair of our Affiliate Relations Committee. And we're so happy that Ben could be with us today. And we have also some very special guests. We have Jessica Moynihan Pollard, who is from NASHMD, the National Association of State Mental Health Program Directors. And also joining to give us lots of information about advocacy and where we can go as we look at block grants and Medicaid is Lindsay Browning. And Lindsay is the program director for Medicaid operations with the National Association of Medicaid Directors. I'm going to begin with some housekeeping. And the first order of business is to thank the Mental Health America Regional Policy Council sponsors for this year. And we're welcoming, as of yesterday, Bristol Myers Squibb, and we also thank Compass and Johnson & Johnson and Myriad Genetics, Neurocrine Biosciences, Otsuka, Pfizer, Sage Therapeutics, Takeda Lundbeck, and last on my list in alphabetical order, but certainly not least, is Teva. So we truly appreciate our industry partners that help make our Regional Policy Council events possible. Another important piece of housekeeping, because I'm sure everybody would like to know, is that this webinar is being recorded and it will be available for download in about a week or so. And the slides will also be available, and you will have permission to download them and to invite your friends and colleagues to take part in the information that will be distributed today and the conversation. I know Jackie's sending you all kinds of messages saying, please do introduce yourself. We're delighted that you could all join us. Tell us where you're from. And also, if there are questions, you can put them in the chat. So we're going to hear from our speakers, and then we'll move to questions and answers. And some might be, we'll be able to type some answers in the chat along the way. So I'm going to right away start by introducing Jessica Pollard, and she's going to lead us off.
Thank you, Debbie, and thank you all for having me join you to talk about this topic. I will do my best to tell you everything you wanted to know about the mental health block grant history, and probably more than that. I won't spend a lot of time talking about myself. Just briefly, I'm a clinical psychologist by background, and I've worked both for a commissioner in the Connecticut Department of Mental Health and Addiction Services and as the director of the Office of Behavioral Health for the state of Maine, which is the state agency that administers the mental health and substance use block grants for Maine. And now I am Senior Behavioral Health Advisor at NASHMD. So we provide technical assistance and supports to state mental health authorities, so those organizations that administer the block grants, among other responsibilities, and provide lots of technical assistance. And I'm going to probably keep forgetting how to advance these slides. So briefly, what the block grant is before we go any further, we should establish the basics. All of the states, DC, and many of the territories and jurisdictions receive the block grant. It's annually appropriated by Congress and then distributed to states on a formula basis rather than being a competitive grant. So the amounts are based on a few factors like population need, costs, and capacity. And then the states administer the programs, either directly providing services or provide grants to subrecipients. And these are intended to fund services that are treatment or support services that have some kind of evidence base for individuals with either serious mental illness or children with serious emotional disturbance. And also give us the ability to collect data that can help us understand how things are looking both at a state and national level. And I've already clicked the wrong thing. I'm not going to go into all the details about treatment. I do have a reference at the end if you want to get into the deep history and all of the nuances of the evolution of both treatment and the background context for how the block grant emerged. But basically, we saw our first state psychiatric facilities in the late 1700s and then an expansion in the 1800s. Didn't see outpatient treatment until the 1913s. And then really with the advent of some of the medication treatments that emerged in the 50s, that's when we started to see interest in this idea that perhaps people could have the possibility or with supports live in the community as opposed to living in state hospitals around the same time that there was much greater attention and concern to overcrowding and poor conditions in state hospitals for a variety of reasons, but also the influence of World War II, people returning with what then was a precursor to what we now think of as PTSD, or what we now call PTSD, and also people, conscientious objectors working in state hospitals. So to give you a sense of the shift when we think about deinstitutionalization, in the 50s, there were over 500,000 people who lived in state hospitals. And now, if we look at a snapshot from 2023, there were a little over 40,000 people who were staying in state hospitals, not necessarily residing there long term. That's a huge shift. And we can attribute a lot of this to advocacy, including lawsuits, but with the advent of Mental Health America, NAMI, and other organizations, as well as research that really demonstrated effectiveness of community treatment. And to give you again a sense of the shift, it's really been a complete switch from the 80s when about 70% or just shy of that of state expenditures were on state hospital costs. Now we're seeing 70% for community mental health. So 40s, 50s, and 60s, a lot of federal policy change. And essentially, Kennedy was a big advocate, first president to address Congress on mental health, had his own family connection and motivation around mental health. And then we saw funding going to community mental health centers, initially for staffing and later operational grants. That's when the first Joint Commission on Mental Health and then Joint Commission on Mental Health of Children was formed by congressional action. And as our friend Lindsay will talk about Medicaid, that's when Medicaid was created and signaled the continued expectation that states support community mental health services with the IMD, or Institutes for Mental Disease exclusion, that prohibits Medicaid funding for institutions that have over a certain number of beds. And I keep hitting the wrong button. In terms of legal background, there were some significant decisions that had far-reaching implications that took place in the 70s. And these essentially established the constitutional right to treatment for people who had been involuntarily committed to a state hospital, leading to the expectation of minimal standards for things like individualized treatment, safety, quality, staff training, lots of different components, but that there do need to be at least minimal standards. and the right to due process, which previously had not been guaranteed or routinely provided. The President's Commission on Mental Health really was you could argue, the precursor to the Mental Health Block Grant. You'll notice when you see the criteria in the block grant that a lot of it comes directly from the language in this set of report recommendations. So making sure we have quality community services, paying attention to diverse needs of racial and cultural minorities, other populations of focus, children, adolescents, and elderly people in rural communities, and that we really wanted to have coordination, make sure there were sufficient funding for services, and that we protect human rights and freedom of choice in that process. And the emergence of the mental health block grant in the 80s, that right around that time was also when we saw the epidemiological catchment area, or ECA, study that I think gave people a sense of just how extensive mental health conditions are. So at that time, the snapshot was around 20% of the population had some identifiable mental disorder, 1 in 3 at some point in their lifetime. And sadly, fewer than 20% of those individuals would seek treatment or had sought treatment. And we really recognized, public advocacy reports that deinstitutionalization had not worked out really well. It overwhelmed community mental health centers, insufficient support for people who had moved from psychiatric hospitals into the community, resulting in really poor outcomes. So this is the act that led to the block grant, and it basically replaced those staffing and operational grants that went to providers with the mental health block grant that went to states. And it allows them to spend funding on treatment, but not hospitalization, not inpatient treatment, and not on things like capital costs. And so I think Ben will talk a bit more about some of the requirements of the block grants. And so I'll just say, there have been changes over time, but basically this law set uh, the baseline statutory requirements that include a planning council, emphasis on a comprehensive service, data collection, reporting on expenditures, and having identifiable targets for how many people we're serving. And so how the mental health block grant is administered, SAMHSA, although it feels to me sometimes like they've been around forever, they weren't created until 1992. The Center for Mental Health Services is the center out of SAMHSA that administers the block grant. They manage the programs, including issuing guidance on the application, reviewing and approving application, and monitoring. Those roles are divided over the state project officers and the block grant monitor. And then states have a designated mental health block grant planner. So that person is responsible for making sure there's timely submission of applications and reporting, collaborates with SAMHSA, collaborates with other state colleagues, since that's necessary in most, if not all, states to gather the data needed for planning and reporting. So states are all organized a little bit differently. Sometimes the state mental health agency or authority is in the same department as other or entities that they need data from, like Medicaid. Sometimes it's not. And they're all structured a little bit differently. And another important role really is working with the Planning Council. So establishing what are the priorities, how are we going to measure them, what are our goals, and incorporates that input into the application. There's also other important things to coordinate with to make sure that the block grant is used strategically. So we don't want to be duplicative. We don't want to spend money from the block grant if it's already could be invested from another source. And most states, or about half of states, I think now, have an Olmstead plan. So what's that plan for moving people out of institutional settings into the community? Let's make sure that there's coordination between the Olmstead plan and the block grant plan, as well as PATH, the programs for assisting from transition out of homelessness. So lots of different things to coordinate and make sure we're all kind of rowing in the same direction. And the state block grant planner can also request technical assistance. I think Ben's going to talk more about the planning council role, so I won't spend a lot of time on this. I will just mention some other updates in terms of the history of the block grant. So language was introduced around evidence-based practices. That term didn't exist when the block grant was first created. Um, there was a set aside created along with an increase to pay for the set aside. So it didn't just take money out of the existing amount. It increased first 5% and then 10% for early intervention for serious mental illness. The modified language that came out of the 2016 Cures Act, which I can provide more detail about. And also, more recently in 2021, a 5% increase in set aside for crisis services. And to give you a sense of how much the mental health block grant has increased, particularly in recent years, it back in 1992, when SAMHSA was first created, the block grant, a federal appropriation or congressional appropriation was 462 million. And as of fiscal year 23, it was over $1 billion dollars for the block grant. So modifications in 2016 really specified things that must be included in the plan. So in addition to those provisions around early serious mental illness, specified the designated single state agency had to be identified, really focused a lot on integration of services and coordination across relevant parts of the system, not just the mental health system, but also law enforcement, social services, education, and really make clear you have to have goals and objectives with milestones and outlining how those activities are going to help you meet those goals. And just to share my perspective on how I thought about working with the Planning Council and my thought from sitting in the seat of the State Mental Health Authority lead, you have to take lots of things into consideration when thinking about your overall state budget for mental health and substance use services. So there are restrictions on the block grant. It can't be used to pay for certain things. It's pretty straightforward. You can't pay for-profit. You can't provide grants to for-profit entities. Can't spend more than 5% on your administration of the grant itself. And I would also be thinking about, we don't want to be doing anything that can be funded by Medicaid. So what are the things that Medicaid can't pay for? Not necessarily what is Medicaid already paying for, but what could it be paying for? Perhaps it's a collaboration with our colleagues at the State Medicaid Authority to be developing new Medicaid programs for the state rather than using our scarce block grant or limited block grant dollars. What are we already paying for out of our state appropriations? What are we obligated to or statutorily required to pay for out of our state appropriations? What are other grants funding? What are our sister agencies funding? Like CDC does a lot of work, for example, around public education prevention. Can we align with SAMHSA priorities? And really practically, can we expend those funds within the time frame of the grant? So states can sometimes have cumbersome procurement, meaning it can take a long time to get contracts executed. I'll wrap up there by leaving you this list of resources, one of which I really want to highlight, which is the State Behavioral Health Planning Council manual that came out in 2023. It's excellent, provides lots of detail, but you'll get the slides with these links that you can click to get more information than I could squeeze into 15 minutes. And I think I'm turning it over to you, Ben.
Well, that's great. Thank you very much. I'm Ben Harrington. I'm the CEO of the Mental Health Association of East Tennessee. And Debbie invites me to participate in these things because I'm older than dirt and been around for a long time. And that includes about 29 years involved with the State Mental Health Planning Council here in the state of Tennessee. So I've been around for a long time. There are a number of things I want to make sure you are aware of. The legislation that was enacted long ago does have some fine print in it that makes our job as community advocates pretty easy because it's in code. Our job is to advocate for the needs of residents of our states and make sure that the plans that are created or reports created by the state mental health authority, that the planning council gets a chance to review those, comment on those, et cetera, and especially to make sure that the um, uh, mental health services in our state, they're adequate. And if they're not adequate, for the planning council to articulate about the need to scale up those services. Also, our responsibility is to advocate to the state mental health authority, the governor, and the legislators in our state about the funding adequacy of mental health services in the state. So we actually have a big job. It's not just convening for meetings and getting to see each other again. There's real work involved. As Jessica did indicate, there are some set asides required in the block grant. So, for example, there is now a 10% set aside um, for it's called FEPI, first episode psychosis. But if you read the fine print, it's really not just first episode psychosis. It is support programs for people with early serious mental illness. So it doesn't have to be limited to someone experiencing the psychosis of schizophrenia, but it can be early onset mental illness. So that's an important thing to know about. The other thing Jessica referenced is the increase in the crisis set aside within the block grant. It had been 5% for a long time, and then it got increased to 10%. That increase was very timely as 988 was starting to be discussed and come into being. And the state of Tennessee actually used some of those increased dollars for the crisis set aside to do its seeding of new 988 type services in the state of Tennessee. So it was very instrumental. But there's more. So the finer print of the legislation is where I like to kind of point people to, because there's been a debate about should we have a set aside for prevention and early intervention. And in the fine print, there is the language about conducting evaluations of prevention and treatment programs and services. So it's there, but it's not fully there in terms of there's not a official set aside being identified. The other thing is in the last section of the bill, and the link to the bill was put in the chat, so I hope you'll copy it and take it home with you, is there's language about reporting to Congress on outcomes of the mental health block grant. And that fine print reads how such activities reduced incidence of suicidal ideation, or how such activities reduced the severity of onset of serious mental illness. You know, I'm going to just be honest, folks. If it looks like a duck and quacks like a duck, it's a duck. Prevention's supposed to be in here. So our walk away for future advocacy work is we've got to get Congress to stipulate a prevention set aside. So how is the state of Tennessee Mental Health Planning Council unique? First of all, Tennessee is a wide state. It would take you about 7.5 to 8 hours to drive from Memphis, the far left-hand corner where it's orange on your screen, all the way to the Virginia border in the far right-hand corner of your screen. So it's a wide state, but there are differences. There are only really 4 large urban areas or metropolitan areas, and then the rest is more rural in the state of Tennessee. So how do you have a planning process that's required by law for a planning council to identify and evaluate the needs of its citizens and make recommendations for improvements. The needs are going to vary from one part of the state to the next. And so there are distinct needs. And so Tennessee has created a planning council system where there is a big council, and then there are 7 sub or regional planning councils. Each of the planning councils in the state of Tennessee reports upwards to the state planning council. And then there are also subcommittees of the state planning council too, an adult services committee, a children's services committee, and a consumer advisory board or peer services committee. But the planning council has that statutory role. It's not only in federal code, but it's in Tennessee state code that our job is to advise the state on mental health services, adequacy of those services, and financing of those services. And so we report to the commissioner. We also report upwards to the governor, and we also go to the legislature. Interestingly enough, the Tennessee Planning Council also includes, by appointment, 2 legislators, someone from the state House of Representatives and someone from the state Senate, serving as active members of the council. So it's a unique way to keep everybody involved. So there are the things that Jessica mentioned. Our job is to advise the commissioner on plans and actions for the department impacting the system. Our job is to recommend legislation for improving services, access to services, reporting, all of that, and especially appropriations. And also our job is to promote the needs of all persons with mental health issues. So there's a lot for us to do. Now, the definitions are very important because, as Jessica said, the definition that is in the Planning Council regulations is about serving people who are SMI, serious mental illness. There are 3 real definitions that we've got to pay attention to. AMI is any mental illness, and that's any onset of symptoms all the way to stage 4, someone who's very seriously and persistently impaired by mental illness. Serious mental illness starts to impact the individual's functional impairment, but serious persistent mental illness means at least 2 or more functional limitations have happened over the past 12 years. We at the Mental Health Association and Mental Health America were very much concerned with the 4 stages of mental illness, and we think we've got to be working at all 4 stages to be able to prevent greater impairment. And so, curiously enough, those reporting requirements to Congress, they want to see what states are doing to prevent people from getting to the SBMI stage. So it really does require that level of oversight and reporting and intervention in each state. So there's an annual needs assessment requirement. And in my eyes, this is what I've been preaching to the choir here in Tennessee and at the State Planning Council level. The annual needs assessment is absolutely where the rubber meets the road in a state like Tennessee, because the Mental Health Authority, the Tennessee Department of Mental Health and Substance Abuse Services, values stakeholder input, values the planning process, and actually supports the planning process with the regional councils and its committees throughout the year. That said, what happens is we're able to identify regional and statewide needs and then feed those recommendations upward to the State Planning Council. They actually come to the committee that I chair, because I chair the Planning and Budget Committee. So I get to see them all, whether it's a need from Memphis or a need from Johnson City near the Virginia border. But it's really important, because where it really, the rubber really hits the road is this. You got 7 planning councils, 3 subcommittees. Is there any overlap of any of those regional planning councils or committees with the top 3 adult mental health needs they recommend or the top three children and youth needs, or the top three substance abuse needs. If there's overlap, now that starts to really put a little bit more pressure on the state mental health authority. It really provides great guidance to the mental health authority, because now they're seeing, wow, there's the ability to fill a need and take something to scale for the state. And that really becomes great guidance for the state planning authority, the state mental health authority, their ability to go when it's budget season to the governor and say, you know, we need to create a program or service to fill this very specific need. Residents of the state are advocating for it. Here's the data behind it. Here's what it's going to cost. And then they can recommend that to the governor and the legislature. So tremendous opportunity. And the annual needs assessment process is where the rubber meets the road for states moving forward. So I encourage you to try to be involved with your planning council if you can. And Debbie, I think I get to turn it over to Lindsay.
Wonderful. Well, thank you all for the opportunity to be here with you today. I'm Lindsay Browning. I'm the Director for Medicaid Programming at the National Association of Medicaid Directors. So what that means is I lead our work to support sharing of best practices and collective problem solving among the Medicaid directors and their teams. Really thrilled to be here, particularly because I have my roots in the mental health space. Many years ago, I got my start working with the American Foundation for Suicide Prevention as an intern, and it sort of sparked my interest in health policy and particularly in mental health policy. So coming back to my roots here with you all today. So I'm gonna cover a couple of things here, and my apologies. Am I moving the slides? Am I advancing the slides?
Yes, Lindsay, you should be able to see the arrows at the bottom and you can move the slides.
I don't see the, oh, yep, I can, got it. Awesome, thank you. So the National Association of Medicaid Directors, we are the professional community that supports the individuals who administer the Medicaid program in all 50 states, DC, and the territories. So as you all may know, Medicaid provides health insurance to about 80 million people, including a significant number of individuals with mental health needs. NAMD as an association elevates thought leadership of Medicaid leaders on policy matters. We amplify kind of their expertise, you know, helping our partners understand kind of what it's like to run a Medicaid program. And then we support the Medicaid programs in that continuous quality improvement and innovation. And we are led by a board of Medicaid directors who are elected by their peers from all across the country. And we also deliver our work through a series of affinity groups that really support not only the Medicaid directors, but senior members of their teams responsible for finance, systems, eligibility, etc. So I will continue here. You all may know this, but Medicaid continues to serve more than 1 in 5 Americans. So it has a really big footprint in being able to move the needle on health and health outcomes for the entire country and to move the health system forward. It really is the primary source of insurance for many different groups of individuals. So low-income Americans, it's responsible for about 40% of births, 33 million children, 2/3 of older adults and people with disabilities. And most pertinent to you all here, it's the largest payer of behavioral health services in this country. What's often not realized or talked about is just how well regarded Medicaid is. The Kaiser Family Foundation, KFF, did a health poll in 2023 and found that 2/3 of Americans have some connection to Medicaid, right? So themselves, a family member, a friend who's been served by the program, and that 76% of all Americans, kind of everyone polled, had a favorable view of the program, and that's pretty comparable to Medicare. So what is the role of Medicaid leaders as you all in your communities seek to engage with and partner with Medicaid? So Medicaid leaders work within a very complex structure to administer the program. They really are the seat of setting that strategic direction for administering Medicaid in their state, while being responsive to the priorities of their administration, the priorities of the legislature, et cetera. They are responsible for ensuring the program gets implemented, that the people who are eligible get connected to Medicaid and receive services. They also have to ensure compliance both with state and federal law. This is sort of a really important aspect of Medicaid, is that it's a federal-state partnership jointly funded by the states and the federal government. And there is a set of requirements, expectations that have to be followed at the state and federal level that Medicaid directors are accountable to. And then finally, Medicaid leaders are accountable to lawmakers, to the governor, the legislature, et cetera, and to the public for the performance of the program. So why am I here today talking with you all? I think it's really important to think holistically about sort of the mental health block grant and Medicaid as two kind of core elements of support to ensure access to needed behavioral health services in the community, and to advance that prevention that we were just hearing about from Ben. So this alignment between Medicaid and behavioral health can really improve the health outcomes by maximizing kind of how these two resources sit alongside one another and leveraging the unique strengths that the Medicaid agency and the mental health authority bring to bear. Now, just being candid here, I think that the degree of alignment between these two programs can differ by state, and they can differ over time. And I think you all will resonate or sort of understand the immense challenge that exists both at the state and the federal level to align these two sources of support for individuals with behavioral health needs. We often see sort of the challenge of alignment existing due to distinct priorities, right? We may see SAMHSA set different priorities than CMS that Medicaid and behavioral health leaders are responsive to. We have different accountability structures, different financing. Medicaid is financed using a federal state matching arrangement, whereas mental health block grant is a block grant. So it's quite different. There's also different language, and we have to learn to sort of speak the same language to be able to advance those opportunities for alignment. And we know leadership change happens a lot, right? Happens at the state level, at the federal level, but that turnover in leadership can impact efforts to create alignment as well. So all of this is to say that the challenge is immense, and I hope that you all will have a deep appreciation for just the lift it takes to advance this type of partnership forward. But there really are significant opportunities for alignment between Medicaid and the mental health block grant. So I'm going to hit on a few of these, and with the caveat that, you know, we're going through a change of administration at the federal level right now. So some of the focus may shift, but from what I've been hearing and seeing from Medicaid leaders, kind of these are some of the key places where mental health, the Mental Health Authority and Medicaid, and you all as partners can really advance that cross-system alignment. So the first one I'll point out is children and youth with complex behavioral health needs. This one continues to be raised by Medicaid leaders across the country as a key challenge, particularly youth who are involved in multiple systems, so involved in child welfare, juvenile justice, et cetera. And I think there's both a desire and a need to, how do we address the urgent need of the day, right? Which is responding to this small, highly complex population that needs highly specialized services. But there's also a desire to get upstream. How do we intervene earlier and provide support for these children and their families so that they don't ultimately end up, as we were hearing about, sort of in that more complex set of needs. So huge opportunity there. The second is around crisis services. Medicaid has been working closely with behavioral health partners around building out the crisis continuum with mobile crisis services. I've seen an increase in focus on crisis stabilization units and also thinking about how do you build sort of the specialized capacity in crisis services to respond to individuals with intellectual and developmental disabilities, as well as mental health needs, and children in crisis, as well as adults. Certified community behavioral health clinics is another area of focus in Medicaid, where I think there's a lot of opportunity for alignment and cross-system collaboration. This is really thinking about how do we kind of enhance and strengthen the specialty behavioral health system. And I think you all as partners can really be at the table in informing what that looks like and what does it mean to have access to that comprehensive array of services. Also seeing a lot of focus on maternal health and particularly improving the outcomes in the postpartum period for birthing persons with mental health and addiction needs. And I think some really interesting opportunities as many states have expanded postpartum Medicaid coverage to 12 months. So Medicaid is playing a more significant role in that 12 months after delivery than it was just a couple years ago. And then finally, there has been a lot of work to implement a federal law that requires certain screening services, certain care coordination services in the pre-release period for youth. That work has been really ramping up over the last year, and I expect is likely to continue. But obviously, a huge opportunity to intervene and support individuals in staying in the community and not re-engaging in the justice system. So opportunity for partnership there. So what can you do? A couple of ideas I would throw out for you all as you look to partner with Medicaid. The first is that Medicaid is often under-resourced and overworked. So I think you all can be a partner to Medicaid agencies to ensure they are well-resourced, particularly to do this cross-system alignment work and to help support them in being able to move it forward. The second is to provide information and data to your Medicaid partners about where you may see misalignment on the ground, impacting the people that these programs serve. There's no substitute for that firsthand insight of where systems are working and where systems aren't working. Similarly, you can kind of broadly offer your expertise on mental health and well-being to Medicaid and share stories about how the program is impacting your communities and opportunities that you see. And then finally, serving as a trusted messenger. Medicaid programs really value partnership with you all to help get the word out about changes that are coming, new initiatives, et cetera. And I know this has been really an opportunity over the last couple of years coming out of the pandemic, where we've seen some really great examples of partnership with community partners to really get the word out about important things happening in Medicaid. So I just want to wrap up with kind of two broader issues in the ecosystem that I think is important for you all to be aware of as you look to engage Medicaid in 2025. The first is that we are entering a period of tightening budgets at the state level. You all may be seeing this and hearing this from the policymakers you work with. But state revenues are beginning to slow. They're lower than they have been over the last couple of years. And that's coinciding with the end of kind of some federal investments in states from the pandemic era. Together, these are sort of putting more pressure on state budgets. And inevitably, when state budgets get tighter, lawmakers look to Medicaid to make cuts and find savings. And this is in large part because Medicaid, if you look at state budgets, it accounts for the single largest component of your state budget. So again, when budgets are tight, Medicaid inevitably gets put on the table. It's also nearly 20% of general fund spending. So when you don't account for the federal investment, it's still the second largest category of spending in your state after K through 12 education. So I just put this on your radar for situational awareness. And as you engage with Medicaid, being mindful of kind of what is the budget outlook in your state can really help help make sure that your perspective, the ideas you're bringing are sort of responsive to the broader environment and the pressures Medicaid may be feeling. The second issue I wanted to hit on that is important context for you all is just the changing federal policy environment. Again, Medicaid is a joint federal-state partnership, so changes at the federal level do impact states, both in the options, the flexibilities they have to administer the program, but also in the requirements and directions Medicaid may have to go. So first, the change of administration is likely to reshape those priorities. We always expect to see a new administration wanting to put their footprint or their perspective on Section 1115 waivers. These are broad demonstration authorities that states can use to test out things in their Medicaid program. So we expect to see a new direction in that space. We expect to see regulatory changes. The Biden administration implemented a lot of Medicaid regulations towards the end of its term, and we are certainly keeping an eye on which of those regulations may be pulled back or rewritten. And then innovation models in Medicaid. We're likely to see the new administration want to test out some new models of care delivery, value-based payment, et cetera. So we'll certainly be keeping an eye on things coming out of the Center for Medicare and Medicaid Innovation. And then finally, Congress is likely to look at some broad structural changes to Medicaid as part of budget reconciliation. I included a couple of potential examples of the types of policies that may be on the table. There's still lots of uncertainty around when a package might move in Congress, the extent to which Medicaid would be included in that. But I think it's important to just be aware that this is happening and that these proposals, could have a significant impact on the financing of the program, who it covers, how it covers folks, et cetera. So good to keep an eye there. So let me stop there, and I really appreciate the opportunity and look forward to discussion.
Thank you so much, Lindsay and Jessica and Ben. We've got some questions. We should have had a question slide. I'm going to thank our sponsors again when we're all finished, but we have some important questions to ask and to ask each of you. And our chat is heating up, but I want to go back and start with people are wondering about the collaboration that happens all the time, the collaboration that happens between NASHBID and the Medicaid director. So I assume you two all know each other well. I know Ben knows you all, and that I've worked with you over the years. And so you've really talked about how important the collaboration is, and anybody can jump in, and then I'm going to get real specific with Ben in a minute, and then I'm going to come back to general. Talk a little bit about how this collaboration really makes a difference as we work all of the levels together.
Yeah. So obviously we try to model the collaboration that we know is so important at the state level, at the federal level, as associations. And one way that we do that is by joining NASHBID's Finance Policy Committee every quarter to talk about kind of key points of intersection and shared priorities between Medicaid and behavioral health. The other way that we collaborate, not only with NASHBID, but a broader set of associations that support state agency leaders, is through a monthly call where we talk through kind of the key issues for our respective members, how we're working together, share resources, etc. Because really the opportunity for cross-agency collaboration, yes, it's critical with Medicaid and mental health, but it really extends to agencies that support older adults, agencies that support public health officials, etc. So we really try to stay closely connected as associations.
Jessica, did you want to add anything to that? And by the way, thank you so much for that important history. I've been around a long time too, like Ben. And I forget that not everybody knows all those important history points. So thank you so much for putting them in there.
Absolutely. Yeah, I'll just add that, to what Lindsay was saying, when I served as the director of the State Mental Health Authority, so incredibly important to be closely aligned with, supporting, collaborating with the state Medicaid authority. And I just absolutely adore Director Probert in Maine. And to echo some of the comments that, most of the state agencies that I'm familiar with are not overly blessed with staffing. And so some of the discussions that I had with advocates were really around, how can we align legislative priorities? Sometimes it's advocating for resources for the state mental health authority, for the state Medicaid authority, because, all these wonderful ideas that advocates have to be carried out by, policy managers, program staff, and it can be really frustrating for everybody involved when we just don't have enough, human power to feasibly get it done timely. So that's important. And then in the collaboration, complementing each other's efforts. Like I know just enough to be dangerous about Medicaid, but not enough to file a state plan. And we wanted to support our MaineCare state Medicaid office in doing some of the heavy lifting around behavioral health policy development. So it can be really complementary, including the role of advocacy.
Thank you for talking about how important advocacy is. I know that's played a big role in Tennessee, Ben, especially in about your crisis system that is really quite terrific, as well as your issues in working with workforce and how Tennessee is handling those kinds of issues.
Yeah, Debbie, you're right. So where this rubber really meets the road is the Planning Council can be instrumental in really laying the groundwork for significant systemic improvements that can happen through state funding, through federal funding, through like Medicaid, or perhaps a combination of both. And so uh, historically, mid 2000s, we had a huge problem with inpatient admissions, as a lot of states did. There was way too many admissions, but the state didn't know how to control that. And so a study really looked at the state hospitals and what was driving that. And what we found were two things, two drivers. Number one, 50% of those admissions were only 1 to 3 day length of stay. That was a problem. The second was that 50% of admissions were also substance induced psychosis, right? So, two problems, which, when you look at it, clearly we needed to have a better way to deflect people away from the front door of the hospital to more appropriately serve people in the community rather than force people to be in a state psychiatric institute. So that was one of the things that we looked at. And the answer was kind of readily in front of us. In Chattanooga, there was a thing called the Crisis Stabilization Unit. And some of us took field trips of volunteers and board members and service providers to go see that facility. And we walked away with a clear mindset. Boy, we could deflect people away from the front door and resolve their crisis in 2 to 3 days. And then they never have to be in the state hospital. And so that's important. We could deflect away and serve people really appropriately. The other part of that with the substance-induced psychosis is it really drove the notion of, boy, we needed to create more substance abuse services so we could also deflect away. And medically monitored detox facilities were created to do that. So that was one way that worked. The other way, what Debbie referenced, was our behavioral health workforce. The Planning Council all started to team together, all 7 regions, all 3 committees, saying we really have to address it and have a unique solution, a Tennessee solution to some of our issues. And that led to a statewide task force that combined the Medicaid Bureau, TennCare, and the State Department of Mental Health to address behavioral health workforce issues affecting both the Medicaid providers and the grantees that contract with the state mental health authority to provide services. And so we could improve our ability to provide a behavioral health workforce that would be able to thrive and continue to serve Tennesseans for decades to come. So all those things really came out of good planning at the State Mental Health Planning Council and the need to coalesce resources to further really identify the problem or the gap or what we needed to do to resolve it, what resources we would need.
Thank you, Ben.
Yeah.
We have folks putting concerns in the chat that I think everybody is concerned about how things are going to play out at the federal level. So I'm going to ask you about, we don't quite know how bills are going to come down with the reconciliation bills. And we know that we're expecting some changes to Medicaid, which we don't know what they're going to be yet. But we know that they have been talked about. They're on various tables, but haven't been put into writing as of yet. We're hearing lots of possibilities. So we know that the collaboration is going to be more important than ever between the planning block grants that we're talking about, the general mental health block grants, and if in fact there are some cuts to Medicaid, which is kind of what we're hearing could happen. We don't know what they are. We can't speculate on them yet. We'll have more information for folks. I know everybody's interested. I'm going to take 1 second to talk about our next Regional Policy Council event, which will be coincide with the National Governors Association meeting. We'll be doing it virtually. It will be on February the 20th at 1 p.m. Eastern Time. We will be thanking the governor for being an outstanding governor. We'll be awarding an award, but we'll also be diving deeply into what we see coming out of the Congress and what kinds of things regarding Medicaid may be coming. But I'd ask you, as we get to the end of this event today, to please just talk a little bit about how important it's already important. It's always important to work together. But as the changes come about, whatever they may be, how will we need to be looking more towards state budgets and doing advocacy at every level of government? So whether it's with the state legislators to say how the impact of cuts will affect states' budgets and what kinds of things, and how we can do that block grant planning process and help make the case for how important Medicaid is to the constituencies that are so important to us. So I'll be quiet and let you answer.
Yeah, Debbie, I'm going to chime in real quick. So the mental health block grant is supposed to be a companion to Medicaid and do things that Medicaid doesn't traditionally do or can't do. It might be resource limited or doesn't have a means to provide a particular service. So any cuts to either one is going to impact the other, because folks are going to have to try to plug and fill to continue things. So it's going to have an impact. I think focusing on return on investment, what the value is, what the outcomes are in each arena or bucket of services is vitally important, so folks at the legislative level know what they're getting for those invested dollars.
Anybody else want to add in something real quick as we close out?
I think I would just share the perspective that, cross-agency partnership is important no matter what's happening at the federal or state level. I think has been articulated, these two sources of support for mental health and well-being really should sit alongside one another and do sit alongside one another. So I would just offer the perspective that I don't think that shared goal, sort of changes no matter what happens in the landscape.
Thank you. Thank you so much. I would like to once again thank the organizations that make RPC possible, and that is Biogen, Bristol Myers Squibb, Compass, Johnson & Johnson, Myriad Genetics, Neurocrine, Otsuka, Pfizer, Sage Therapeutics, Takeda, Lundbeck, and Teva. And you'll all be getting information. We'll be putting it out through our mental health channels, Mental Health America channels, about the event on February the 20th, where we will be recognizing an outstanding governor who's done wonderful things for mental health. And we'll be talking about what we're seeing at the federal level and how that may filter down to the states, and about advocacy that you can all use. Again, this is being recorded, and you will have the recording in about a week, and the slides are also available. I want to thank you all once again for joining us. We really appreciate it. So thank you.
Thank you.